A very good morning to you. I'm Howard Feldman. This is the Synthesis podcast focused on COVID with me, Howard Feldman, and pulmonologist and physician, Dr. Anton Meyberg. It is the 30th of December, 2020. And just like that, the world ends, not with a bang, but a whimper. I didn't say that, somebody a lot smarter than me did, but it really does feel like that. We're heading towards the end of the year, and it seems to be with a whimper. People are tired, holidays have been disrupted, the numbers are rising. We are hearing reports that the new strain or the is about 70% more infectious than the last one. It's very, very scary out there. Lots of people are confused as to what January 2021 is going to bring, which is why we've gathered together today to talk about it and to actually answer some of these questions. Dr. Anton Meyberg, I see that you are still on your holiday. It does look beautiful in the background. How are you doing? Have you had a break at all?
Well, first of all, I hope your prediction doesn't come true and the world doesn't end, regardless with being whimper without a whimper. But yes, we're still on holiday and we're going back to the war zone in the next week. I'm not looking forward to that. I think it's going to be quite busy and quite hectic, and it's going to be much worse than the first wave was. There are currently 82,327,498 cases worldwide, with 1,796,545 deaths and 58 million cases resolved. The United States has 19,977,000 cases with 346,579 deaths. That is 1 per 1,000 deaths per people from COVID-19. South Africa has 1,021,451 cases with 27,568 deaths and 9,580 new cases in the last 24 hours. The cases in Gauteng in hospital are sitting at 2,344, with 428 in ICU and 149 ventilated. There's been a major surge in the Eastern Cape and Western Cape, and the surges are going up in KwaZulu-Natal and Gauteng, the two most populous provinces in our country. We haven't reached the peak of the second wave in Gauteng yet, albeit they have reached that in the Eastern Cape. The Western Cape, KwaZulu-Natal, Gauteng are increasing rapidly, but the Western Cape seems to be plateauing at the moment. We hit a record high of 14,796 cases over the Christmas day. And of interest is that the numbers taken to reach the 100,000. So 500,000 to 600,000 cases happened in 20 days, 600,000 to 700,000 happened in 56 days, 700 to 848 days, 800 to 900,000, 15 days, and 900 to 1 million happened in 9 days. So this virus is spreading exponentially. It is highly transmissible, and we need to be really on top of what we're doing and how we're acting and how we're behaving at the moment.
All right, so let me just ask you a whole bunch of questions before we get to some of our listeners' questions. The first question I need to know is, why is it that, and we've read about this, we've heard about it, but now we're seeing it, that a second wave is often more deadly or more virulent than the first? Is it because of our own behavior, or is it the virus itself that determines this?
So I think that's a great question. I think there's two reasons for that. First of all, is the virus itself. There's a much higher transmissibility with this variant of the virus. It's far more contagious, 70% more contagious than the first wave. And that's because of the genetic mutation of the virus. You know, it's an RNA virus. All RNA viruses mutate. That's what they do. And this one has mutated. And a mutation basically means there's a change in the structure of the virus itself. So once that change happens and it replicates differently, you get a genetic mutation, you get a different strain of the virus. That being said, people have been fatigued, people have not been following the rules, people have not been wearing masks. You get a lot of your anti-vaxxers, anti-maskers, people, anti-COVID-19 people who don't want to follow the rules. And unfortunately, we're seeing the repercussions of all these things now.
The numbers in the hospital that you're involved with, I know that every time we've spoken and we've tracked it since there were practically no cases following the first wave, it went up to 4, 8, 13, 20. Where does the hospital sit now in terms of cases?
So they're sitting at over 50 cases, multiple people on ventilators, multiple people in ICU. The wards there's no more elective surgery being done, and the wards are being closed down that aren't able to put in COVID patients because of it being so highly transmissible. So hospital is reaching capacity dramatically soon.
And that's in Gauteng.
And that's in Gauteng. I'm talking about the Gauteng hospitals. And I think it's very pertinent to discuss something now while we're speaking about the hospitals. You know, last night, Richard Friedland came out with a message. He's the CEO, the Chief Executive Officer of Netcare, and he came out with a message that he wants to put across at the emergency departments and for patients and people to understand and recognize that. And I think it's important that I read this message because it's a very important message. It says that the recent surge of cases have placed significant demand on our facilities, requiring us to make decisions regarding access to care and certain treatment modalities. All of these decisions are based on recognized international guidelines of triage, which is allocation of treatment based on priority and transition of care. Our clinicians, nurses, and management teams will provide the best care available to our patients, but may not, in circumstances where the demand exceeds or overwhelms the capacity, be able to provide all treatment options that may be available in a normal, non-pandemic circumstances. Practically, this may mean that levels of care such as ICU, high care, ventilators, or certain oxygen delivery modalities may not be available to all patients at all times. Our clinicians will make these decisions based on the availability of resources and their best clinical judgment. We fully support them in this difficult task and complex decision-making process. May we also humbly request your understanding, as we may not be able to provide communication updates as regularly as we would in normal circumstances due to the demand on our clinical and administration staff. We are currently implementing initiatives to improve the communication. And I think that's important to know and important to understand that we are in a war zone. We're in a battlefield. This is far worse than the first surge. This is much worse, okay? And you have to have patience in understanding what the healthcare workers are going through that are treating these sick patients, and knowing the fact that these patients' families are desperate to understand what's going on. It is a lot of times very difficult to communicate with people when you're in PPE for 15 to 16 hours a day and trying to treat as many patients.
And I think that's very, very important, is just to, I guess it's a responsibility that's been added to our responsibility as lay people, is we need to be careful, but we also need to be quite understanding of the situation. It is imperfect. We are living in a very, very difficult and an unusual situation, and we just have to suspend maybe our normal expectations with regard to maybe the niceties.
100%. I cannot agree with you more. There's no one's going to be turned away from a hospital or not be given care. Everyone will be done as much as possible within the realms of human possibility.
Right. Let's just talk about this mutation, because there's been a lot of talk about this, about it impacting younger people, being more contagious. Is it more aggressive? Are people getting sicker? What are you seeing?
So let's talk about the SA variant that we're going to talk about now. And there's increased transmissibility with this variant, more contagious. You know, people who've been to parties with increased amounts of alcohol at these super spreading events, it's the ideal environment for the virus to spread. People let their guard down, they take their mask off, they start hugging and embracing. And this is called the 501.V2 variant. And that is, in scientific terms, it's the 501st amino acid, where we get an N-chain amino acid that is replaced by a Y-chain amino acid, which is very scientific garble, but that just explains why it's called the 501V2. The same mutation has actually arisen in the United Kingdom. They call them theirs the 2020/12-01 mutation, and that's their Kent mutation. That's very interesting because it's a different evolutionary origin, but both of these mutations have originated separately. And this is a very dominant strain. You know, it has 3 mutations associated with it. And there are multiple changes in that spike protein. So if you think about the actual ball of the coronavirus with all those sparks coming out, there are multiple changes in those sparks. And these are the parts of the virus that bind to the receptors on the cells, and that's the target of your antibodies. And there's a change in that spike protein at the 501 position, that amino acid position. And it was first identified in Nelson Mandela Bay, and it spreads through Eastern Cape, Western Cape, KwaZulu-Natal, and now Gauteng. And one of the defining turns of the spread of this variant was the matric rage, which helped to spread this new variant. Yes, it was around before then, but this definitely was a super spreading event. And, you know, we understand that SARS-CoV-2, which is the virus that causes COVID-19, like all other viruses, does mutate. But it's a natural process for it to mutate, and it's a natural process for it to have variants. And this is what's happening, that this virus is mutating. And you can take it even one step further to say, well, if the virus is mutating, what about the vaccines? Will they actually play a role here? Mm-hmm. And we seem to think that they will. At this point in time, from what people understand, they will play a role. They will be able to treat these mutations of this virus because it's still the spike protein that we're dealing with.
So in terms of treatment of this virus, you know, we've come a long way. And one of the things I wrote in an article yesterday is that although there's reason to start 2021 with some trepidation, the reality is that there is a virus, that there is a vaccine that is sitting, waiting in the wings. Hopefully South Africa will get it sooner than later. That's the first thing. The second thing is that we understand the virus a lot better than we ever have. Obviously, because we're 12 months down the line in terms of the virus being known to the world, and thirdly, the treatments that we are using seem to be a lot more effective. What treatments are you currently using, and how effective are they?
So yeah, I think that's also a very important point. It's not all doom and gloom. You know, we aren't just here soothsayers of doom and the prophecies of negativity and all these things. Yeah, 100%. I'm trying to make myself sound better. But the point on that is that the duration of stay of people in hospital is much shorter, we're seeing, than the first day. So during the first state of the first surge, people in hospital for anything from 10 to 22, 23 days. Now we're seeing that even though they're sicker, they are staying in hospital a lot longer. In other words, they can stay in hospital from 6 to 10 days only. And that's the majority of the patients that are staying in hospital, which is a huge, huge improvement in your actual outcomes of your patients. Yes, there are deaths, and yes, there are critically severe patients, but the treatment modalities we're using have not changed much from the first round. The only difference being is that the vaccine has now been introduced overseas, which will hopefully be coming to us in the next year. But that makes a big difference with regards to treatments. But we're still using the same vitamin concoctions. We're still using remdesivir. We're still using tocilizumab, the monoclonal antibodies, convalescent plasma if available. We are still using all these modalities, dexamethasone, the corticosteroids, the blood anticoagulation elements, all of those things which we've got in our arsenal of treatment that we can use to treat people and help people. And we definitely have learned so much over the last year. I mean, I actually can't believe it's been a year since this has all come out and this has all happened. But we've learned so much, and it's definitely held us in stead. It's definitely helping us to try and combat this virus and to try and treat it and to try and get people out of hospital quicker.
Right. So the treatments are, and what percentage of people actually land up in hospital, people with COVID land up in hospital?
So about 10% of people land up in hospital, and 5% of those people are critically ill.
Right. Okay, so when we look at our numbers, 10%, is that considered a high number medically?
It is considered a high number. It really is a high number. You know, people say there's only 99.5% people who are getting unwell, like that 99.5% people that are well, but it's only 0.5% that are sick. You just need to step into an ICU. You just need to step into a COVID ward to see what the reality of this virus is. Speak to somebody who's been sick, who's been really sick, who hasn't even had to go to hospital, who stayed at home and has been coughing, has been short of breath, who is feeling like they can't move around, who's fatigued, then you'll realize the reality of the virus. To all those naysayers and to all those anti-vaxxers, let you, God forbid, get the virus and then see what it's about. And then you'll understand why we are so overwhelmed and why we are so positive about the fact that we need to put in all these non-pharmaceutical interventions and look after ourselves.
But I can't ask you really to go into the mind of a naysayer, but I mean, we see them on Twitter, we see them all over the show saying, you know, how ridiculous this whole thing is, and it's, what do you think is the agenda there? I mean, there's some doctors that are promulgating this type of.
Look, they're naysayers in any type of field in life, whether it's regarding to religion, whether it's regarding to health, whether it's regarding to science, whether it's regarding to anything, you know. I can't tell you what goes through the mind of something like that, but I can tell you these so-called naysayers, not one of them is on the front line working with the sick patients in ICU that are needing to be ventilated or dealing with the repercussions of this. They all think they are, but none of them actually are. And you cannot be a naysayer or someone negative until you've actually worked in ICU and realize what it's all about, because then you'll see what it is. And I challenge these naysayers, come to ICU, don't wear a mask. Don't give yourself PPE. Come and help us clean the ICU patients. We need help in the hospital. So please come ahead, come and help us. And then we'll see what happens thereafter.
Mm-hmm. A lot of people asking, Garen, Laura, Ilan, Stacy, a lot of people are sending us messages about ivermectin. Has it been banned in South Africa? What is ivermectin, and can you take us through?
So we've discussed ivermectin before. Ivermectin is an antiparasitic drug used by vets. Okay, it treats river disease and all these type of parasitic illnesses, and it works extremely well in animals. It did make headlines as a so-called miracle cure for COVID-19. It's not approved by SAHPRA, that's the South African Health Professions Regulatory Authority, and it's not indicated for use in humans, but it is well-established use as a veterinary drug. Obviously, there are plenty of camps overseas that are using it, but for the amount of camps that are using it, there's triple the amount that aren't using it, and there's no peer-reviewed studies that show that it actually worked. The amount of ivermectin you need to treat it is potentially toxic to the human body. We're talking about grams and grams of ivermectin, and it's not a miracle cure. So we're not withholding medication from people. We don't want people not to get better. We want people to get better. So if we can give people medication to get better, we'll give it to them. But we as a body find there's no benefit to using ivermectin in people at this point in time, and none of the studies prove us otherwise. Just because randomized groups are using them overseas doesn't mean it's peer-reviewed. People are desperate, people have got their backs to the wall, and people are trying all other things. It was the same with hydroxychloroquine. People were desperate. People were touting it on TV. Presidents were saying it, use bleach, use hydroxychloroquine. At this point in time, ivermectin fits in that box. That once again, we can't be too arrogant. Things can change, but until we've got regulated studies or peer-reviewed studies on these things, we cannot be blasé and arrogant enough to use this without realizing that there are repercussions and side effects from these things.
Let's just talk about the current situation, because many people are away, they are on holiday or wherever they are, and they might have come across somebody who is positive, who has been exposed to the virus. Can you take us through those protocols again, because they are absolutely critical?
Yeah, so I think that's the thing, those protocols keep on changing, and I think it's something we need to hammer into people. It used to be 14 days, then it was 12 days, then it was 10 days. So now if you are symptomatic, okay, if you have been exposed to it, you need to isolate for 8 days if you are positive, okay? You have to be absolutely, completely isolated and quarantined for 8 days if you are a positive person with the virus. If you are in contact with somebody, those you're a primary contact, you have to isolate for 10 days. And that, I think the most important part of that is, doesn't mean that on day 5 you can go have one of those quick antigen tests which come back negative and say, well, then I can come out of my quarantine and then I can get on an airplane. You cannot get on an airplane. You cannot come out of quarantine. You need the full 10 days, because the worry is that the test, your viral load can be extremely low and the test doesn't pick it up at any stage in that 10-day period, and therefore it be a false negative. So therefore it's mandatory for you to stay in that quarantine for 10 days, and mandatory for you to stay isolated if you are positive for 8 days after symptoms develop, as long as you're getting better and there's no further symptoms.
Yeah, because I think it was Dr. Sherry Fanarov also dealing with this quite extensively and saying, please, can Anton Meyberg discuss that? Because very obviously what she's seeing as well on the front lines must be something similar, that people just
people are making excuses to get on airplanes to come home so they can get home because we won't infect other people, we'll be okay. People are trying to bring their temperatures down so they don't have temperatures in the airplanes. I mean, it's just, it's unbelievable. You have got the need to protect people. You have to protect other people. When you are sick, you cannot get in a plane and spread this amongst other people. It's a social responsibility.
Alan says, is it better to drive home from Cape Town, or is flying still safe?
Look, I mean, that's a personal decision you've got to make. Me personally, I'd rather drive home. Okay, I think, which for me, it's a much safer option, where you're not exposed in the airport, you're not in long lines, But if you are flying home, make sure you wear a mask, a visor. You keep on sanitizing your hands. You don't take the mask or the visor off from the time you get to the airport until the time you get out of the airport. Keep on sanitizing your hands. Don't eat on the airplane. Don't interact with people in the airplane. Just sit in your seat and just stay basically still until you get off that plane.
Mandy says, I know someone who tested positive. His wife then went and was tested and she was negative. Is it possible that there are a lot of false negatives coming through?
So, look, we've seen that very often, and that's a very good question, because a lot of the time a spouse can be extremely ill, they end up going into ICU, and the other spouse is at home and well, no symptoms, negative, and we don't understand the variation or the mutation of the virus, why it affects some people, why the receptors pick it up and other people don't. So we can't explain this, and we don't understand it extremely well. But it is very, very possible that it does happen, and it's not necessarily a false negative. It just is the fact that those people won't pick up the virus. And maybe they do have antibodies from a previous coronavirus, or maybe they have got T cells, which gives them memory cells to the virus. Who knows? I think time will tell.
And Mandy's also asking about her son who lives in Israel. Would you encourage him to get the vaccine? I think we're going to go with a hell yes.
Yes, and yes. And right, let me think about that. Yes.
You know,
and if he doesn't want the vaccine, we're happy to go there and get the vaccine ourselves for him.
Right. You know, my approach is, I think my whole slogan around the vaccine would be hold them down. Just hold them down and jack them. It's as simple as
Texas hold them.
Yeah, but we can do it locally as well. Right. Other questions that we have.
Interesting. Speaking about the vaccine, there was an article that came out in Eyewitness News this morning that the Oxford vaccine, the AstraZeneca vaccine, has been approved for use in the United Kingdom. They have ordered 100 million of those vaccines already to vaccinate 50 million people. That's a very positive thing, because we've been involved in the research and the studies in that trial in South Africa. And that means there's a higher chance of us getting that vaccine sooner as well. So hopefully that will boost our chances of getting vaccines sooner than later. It's a much better vaccine for the South African purposes, because it can be stored in a fridge, and it's a once-off dose, not a two-dose vaccine. So it works very differently to the RNA virus, because it works on the preface of an adenovirus, which is injected into the body, and that itself introduces the spike protein, which creates antibodies without actually infecting the person.
And a few people asking, do you foresee, and I don't know that you'll be able to answer this, but do you foresee that as this virus mutates, like the flu vaccine, we'll have to get annual top-ups maybe of the vaccine?
I think so. I think that's a question that everyone's been dabbling with, and I think that is the answer. I think once we get that herd immunity, once people are vaccinated, we'll see, very similar to the influenza vaccine, on a yearly basis, people will have to have corona vaccines.
A few people asking, if somebody's been in your house, how long will it stay in the air? If a contractor, for example, they've been in your house fixing something, how long, and they've stayed out the house, how long before it's safe to come back into the house?
Look, I think you've got to take it one step back and say, if somebody does come in your house, make sure your windows open, make sure your doors open, make sure there's good airflow, make sure anybody who does come in your house is wearing the minimum of a mask, okay? If a contractor comes in the house, make sure they're wearing visors. Then you've got less of a problem. Make sure they put a hand spray in the front of your house, put the hand spray in your kitchen, that they can actually vaccinate, they can actually sort of clean their hands and cause hygiene throughout the whole house, and there's less of a chance of the spread of the actual virus. It's very difficult to say that they would be in your house and then therefore promulgate the spread of virus by just being there. So if you want to be safe, just keep all the doors open, keep the windows open, and allow good airflow through that area for an hour or so, and that should be fine. If it comes back, let's say that the contractor was positive, okay, when they've been in your house, and they were in your house for an extended period of time, for more than 15 minutes, then you can say, well, leave that area for about 24 hours, give it a deep clean, or you can fog that area.
Okay. And fogging is a safe method as well. You're comfortable?
It's safe, but just more expensive than deep cleaning and leaving the area for 24 hours.
Right, I understand. And let's just talk as well about a lot of questions. Should people be buying school shoes for their children?
So that's a very, very difficult question. And I think that's a question that's going to have to be answered by school bodies and their medical representatives regarding that type of thing. You know, we still say that that it's not a super spreader amongst children. And we talk about children about the age of 12, 13, 14, 15. Once your child's 18, they're not a child anymore, they're an adult. That's a completely different subset of person. But the epidemiological variants are still out there. We don't know for sure. Yes, there are more people who are sick, and there are more children that have been sick. We don't know why, but we don't see it as a super spreading thing. And, you know, I would obviously like my kids to go back to school, but I think that's got to be something that's discussed on a school basis in a different forum completely, to see what the comfort zone of the school is and what the spread of the virus is in that area or in that cohort of people before you go back to school.
But isn't it logical that as people are regathering from different parts of the country, that we have a holding period? That, let's say, as people come back, that we have a period where we act, and in fact we do have that government period at the moment, the 2 weeks. But really, when people come back, isn't it logical that businesses that can work from home, schools, etc., and I don't want to draw you into necessarily a discussion that you aren't ready to have yet. But the reality is that, to me, it's just logical that people will come back, stay put for 2 weeks, make sure that they aren't...
Yeah, you see, you've lost me there already, because there's no such thing as logic with this virus. There's no such thing as logic with people. Once you keep people and people, you say people must come back, then they're going to start socializing together, and they're going to start doing other things together, despite the lockdown facility. So there's no logic in this, you know. There's no common sense. We'd like there to be common sense. We'd like people to actually not interact with people.
Would you agree with that as an approach? That people come back from their holidays, stay put.
If you're going to go back to work and you don't have to go back to work, you can do things, you know, online at work. That would be an ideal thing. But, you know, it's not always ideal. And it doesn't mean that people can afford to do that or people are able to do that. And that's why you've got to actually sort of challenge each situation differently.
Right.
But you also got to look at the fact that which are the super spreading populations and which are the non-super spreading, and who are the more relevant people to get sick and who are the comorbidities. And there's a whole different sphere of things to look at with regards to that. So I am actually quite dancing around that question, because I think that's something that's a personal thing between schools and between, you know, school bodies and their medical representatives.
Look at their situation.
At their data, yeah.
Right. Selwyn says, are we not in the situation because people chose summer holidays over keeping the numbers low?
No, we're in a situation because of the fact that people got fatigued and people stopped caring and people stopped wearing masks. It's got nothing to do with holiday. It's got to do with super spreading events where people were imbibed in alcohol, people socialized together, people were in close contact together and weren't following the rules. And that is the actual reality of the whole situation.
Charles says, my wife has a severe backache. We are currently in the garden route. Do we go and to an orthopedic surgeon, get x-rays, or do we rather wait a while?
Look, that's, once again, it's a personal thing that you've got to decide how bad it is. If you can't manage, and you go see somebody. If not, speak to your GP and they can maybe advise you what to do. But if you can avoid going into a hospital at this point, I would avoid it for now.
Absolutely. Jonathan asks an interesting question, and it's again back to everybody returning. People are going to be returning from their holidays, those who have been away. Domestic helpers are going to be returning as well. What would you recommend the protocols are on returning home?
Yeah, I think before we single out domestic workers, why are domestic workers any different to somebody else who's coming back from holiday? You know? Because you think you've been safe.
I'm looking at both sides. I'm looking at people infecting.
Look, we're all worried that our domestic workers have gone, let's say, to the Eastern Cape and they haven't been careful. Then yes, quarantine. But if you've been to the Eastern Cape and you haven't been careful, then you also need to quarantine. It's the same thing, because you've also got other people to protect, not only yourselves. But I think that we're in a stage of the virus now with this variant and with this mutation that we have to be really careful. So you really have to make sure that you're protecting more so than the first wave, that you're more protective of yourselves, of your family, and of people around you. So it's in no ways a bad idea to make sure that you or your staff quarantine if you've been exposed in different areas where there's a high hotspot or a high viral load in that area.
Susan is asking a question about a group of people living in a shared facility. They each have their own room. And she says, how long should a group home be in quarantine after one person has mild symptoms and tested positive? The rest of the people have stayed in their rooms since their diagnosis. No one else has had any symptoms.
Well, that's a difficult question to answer because are they sharing bathrooms? Are they sharing communal areas? If you're sharing communal areas, then it's 10 days. There's no doubt, but it has to be 10 days. And on the safe side, I would say 10 days because then you can make sure that there's no, and there's no point in testing if you're asymptomatic, rather to do the full 10-day period.
Right. And we are running out of time, but is there good news?
So there is good news. And I think we've got to realize that it's been a year that no one could ever have predicted. 1 year ago today, we were oblivious to the fact that there was a pandemic on its way. It's been a year of solitude. It's been a year of loss. It's been a year of pain, of fear and anxiety. But one thing is for certain, we have seen our community rally in this last year to look after the aged, to look after the sick, the less fortunate. Despite adversity, people have persevered. We will get over this. We know that. We will overcome this. This too shall pass. And of course, the most important part of the good news is Liverpool on top of the Premier League table, you'll never walk alone. And I think the quote is quite a pertinent quote that I'm going to say. It's quite a long quote, but it's quite important. The Ugandan President Kaguta Museveni is warning against people misbehaving during this COVID-19 period. He said the world is currently in a state of war, a war without guns and bullets, a war without human soldiers, a war without borders, ceasefire agreements, or sacred zones. God has a lot of work. He has the whole world to look after. He cannot just be here in Uganda looking after idiots. And I think that's quite pertinent, and I think it makes quite a lot of sense. So let's look after each other. Let's look after ourselves. We have a long road ahead. We have lots of work to do. It's going to be a very tempestuous and very tumultuous time ahead of us. Let's look out for those unicorns. Let's look out for those rainbows. God knows we need them. Be safe and look after yourself.
And I think that right back at you, Dr. Anton Meyberg, you're going to be returning to Johannesburg, as you said, to the war zone early next week. Godspeed, and may he protect you and your family and all those around you so that you can obviously continue to do the work that you are doing. And the way that we can help you is to try and be as careful as we can be during this time. Please look after yourselves. Please look after each other. I wish you all a blessed 2021. Be safe, be responsible, and God bless.